Mr. Chairman, distinguished guests, distinguished colleagues, it is a pleasure for me to be here at this beautiful part of the world. And I would like first of all thank to Professor Tinika and Batrinak for inviting me to this excellent meeting. The previous lecture has covered the whole issue, so I will just try to give a short comments on some points of tricuspid valve repair and replacement. As you know, tricuspid valve disease can be due to secondary causes. Mostly, almost 70% of the tricuspid regurgitation occurs due to left heart disease, left ventricular dysfunction, or valve disease resulting in pulmonary hypertension, or any cause of pulmonary hypertension. Also, 25% of all tricuspid valve disease are primary causes. And as you know, rheumatic, degenerative maximatous disease and Epstein, etc., they are so easy, and to approach for them are already well defined. Therefore, secondary and tertiary causes are much more controversial issues that we have to address and discuss. If we look at the primary TR, usually, as I told you before, it can be easily fixed or it can end up with TVR. And just to distinguish both functional or organic TR, we need, of course, echocardiography, but primarily right atrium and right ventricle are enlarged in primary tricuspid regurgitation. But when we look at secondary or functional one, we usually can see that left ventricle and left atrium also are involved. Just as an easy approach as a surgeon, when we deal with primary tricuspid disease, we perform an isolated tricuspid surgery, which is very well defined, as I said. And for the functional or tricuspid disease, we perform an concomitant tricuspid surgery, which is usually a little bit complex because of the right ventricle and left ventricle disorders. And when we look at the tertiary tricuspid disease, they are neglected tricuspid regurgitation during the first operation or progressed after the first operation. So basically, they are redo tricuspid surgery. So it's much more, usually much more complex. Imaging is very much important, and transthoracic echocardiography, as it was mentioned, is very much important. And there we need just to make a distinct decision about the whether we will repair or not. We need quantitative measurement of the regurgitation. So vena contracta or PISA method, but usually vena contracta is much more accurate, especially if the vena contracta width is around 70 millimeter. It defines severe tricuspid regurgitation. And also PISA method is accurate, but currently we use much more vena contracta. And systolic hepatic flow reversal is also important. I don't know how many of the audience are cardiologists here, but you know better than me about all these details. In the presence of TR, tricuspid annulus, as it was mentioned before, is very much important. We decide if we carefully measure it, if it is over 40 millimeters, or new concept is 21 millimeter per meter square of body. Then tricuspid surgery is indicated. So as you can see, we have now very distinct or strict parameters. Also, clinical signs are very much important in evaluation of tricuspid regurgitation. Therefore, if we have all markers of clinical markers, it is important. But as we all know, use of diuretic and unloading by diuretics can help to, I'll mention later, to tricuspid regurgitation. So the clinical signs can be very much dependent on diuretic therapy usage. And also, we have to decide about the right ventricular function, and TAPSE, which is tricuspid annular plane systolic excursion, is very important criteria, and it must be below 11 centimeters to decide about the regurgitation and surgery. And recently, CMR is becoming very important standard. Let's have a few words about tricuspid stenosis. And again, here, the gradient is very important. If we have over 5 millimeters, it's not like mitral 10 millimeter or so. If it is over 5 millimeter, it's an important tricuspid regurgitation, and we can either, and of course we need a symptomatic case, then we can perform either catheter valvotomy or by percutaneous way or surgical one. If the valves are non-pliable, we can perform a valve replacement. Indeed, there is no reliable method nowadays to predict how much of the TR will reverse after correction of left heart valve dysfunction. And experience indicates that a significant and varying percentage of patients will have recurrence of TR during follow-up, even with a perfectly functioning left-sided valve. This is particularly true in rheumatic mitral valve disease as opposed to degenerative disease. In ischemic mitral regurgitation is also prone to late recurrent or de novo TR. Current guidelines, both EAC and EAC-AX and ACC-AHA recommendations are based on expert experience and opinion and still hold minor differences. I'll show you later a little bit. If you look at the guidelines of EAC and EAX, they were reviewed in 2012. As you can see, surgery is indicated in tricuspid stenosis as class 1 indication, and at the level of C. If the symptoms are severe, again, in tricuspid stenosis, it's class 1 indication. Surgery is indicated in patients with severe primary or secondary TR undergoing left-sided valve surgery. It's again valve class 1. Surgery is indicated in symptomatic patients with severe isolated primary TR without severe right ventricular dysfunction, class 1. On the other hand, if you look at the last one is very much important. After left-sided valve surgery, you perform left-sided surgery, and then no tricuspid approach, and then patient becomes symptomatic and dilatation or dysfunction of right ventricle, then again just primarily for tricuspid surgery to perform tricuspid surgery, it is class 2A indication. Between ESC and EACS guidelines and American guidelines, there are just a few differences. Especially tricuspid valve repair is beneficial according to ACC, American one, for severe TR in patients with MVR as a class 1 indication. So Americans are believing in surgery a little bit more. How about the medical therapy? Yes, medical therapy is very important, and as for medical therapy, diuretics are used to reduce venous congestion, and the degree of tricuspid regurgitation clinically and symptoms can disappear after unloading, although there is a severe tricuspid regurgitation. Again, all the other angiotensin receptor blockers, even beta blockers can help. To the as the medical therapy. Timing of the surgical intervention remains really controversial. Mostly surgery is limited to tricuspid valve is recommended in symptomatic patients with severe TR. This is important. We don't go for surgery usually if there is not a severe TR. As a general principle, if technically possible, of course we perform valve repair, and it must be done before having an irreversible right ventricular dysfunction. Tricuspid surgery, severe RV or LV dysfunction, or severe pulmonary vascular complications should be considered in patients with moderate primary TR, as well as in patients with mild or moderate secondary TR and significant dilatation of the annulus over 40 millimeter. Here you can see, do you think that should we accept primary TR as a benign condition? This is an interesting paper. It has been done in more than 5,000 patients, and who has just mild or moderate TR. They were followed, and almost 74% of mortality has been seen in some of these cases. So mild or moderate TR is not it doesn't seem a benign condition. As a concomitant tricuspid surgery, there are some key points. We must know that it's a progressive disorder linked to continuous right ventricular remodeling, does not simply resolve after correction of left heart lesions, is associated with adverse clinical outcomes. An aggressive surgical approach correcting functional TR concomitant with left heart procedures, including left ventricular implantation, is nowadays gaining some trend. But there is no prospective or randomized comparative trials evaluating tricuspid valve regurgitation. Therefore, really our daily practice is limited. Our practice is usually depending on our own experience or some observational data like this. This paper is coming from Cleveland Clinic, but still it's not it is an observational paper only, and it shows if moderate or tricuspid regurgitation with left-sided degenerative heart valve disease should be repaired or not, and it has been done only in 1,700 patients, but in 10 years or so, and who has 2+ tricuspid regurgitation, and only 91 of them had tricuspid valve repair. It is about 5%. And then they are giving a very strong conclusion, saying that repair only applied to impaired right ventricular function or enlarged right ventricular echo findings. Also, they are saying that for tricuspid regurgitation, 2 plus tricuspid regurgitation, if there is a concomitant left ventricular problem, it is feasible. But the numbers and the performed operations are not very much. Again, the paper coming from Dreyfus is an observational paper. It's not a randomized trial. Again, it's around only 300 patients in 10 or more than 10 years, and conclusion is again too strong for such a paper. And remodeling annuloplasty of the tricuspid valve based on tricuspid dilatation improves functional status. So irrespective of grade of regurgitation. According to this paper, according to Dreyfus, we have to perform tricuspid valve surgery in all concomitant tricuspid regurgitation. It is a little bit too much because there are some papers showing that also, if you look at this, if you look at the C, I cannot show you from here the paper, the part at the C part. Freedom from that. Probably this is the pointer. Here, freedom from that and congestive heart failure and tricuspid valve operation is similar in the repair or no repair group. So it's controversial. You don't need to repair all the time when you have repair, when you have a tricuspid regurgitation. Also at this paper, you can see a little bit higher mortality in when you are performing concomitant tricuspid surgery. Why? Because why tricuspid repair and replacement is less satisfactory than left-sided valve surgery? Because it is a disease of, it's not disease of valve only, it's the disease of valve, myocardium, and both, even disease of pulmonary artery vasculature. So we have to be a little bit careful about decision making. Repair in mild or moderate secondary tricuspid regurgitation, if we decide like this, if annulus is dilated considerably, as I mentioned, over 40 millimeter, if right transverse diameter is over 60 millimeter, if right ventricular and diastolic diameter is over 60, if pulmonary artery pressure is over 45 or 60 millimeter. And ring annuloplasty is usually done, but there are a lot of techniques that we can perform. I know that most of the audience is not surgeons, so I'm not giving very much insight about the techniques. Tertiary tricuspid regurgitation is basically, as I mentioned, redo tricuspid surgery. And in redo surgery, there are some papers like this, which are very, discouraging us, but it's not always like this. Hospital mortality like 35%, because I think it's just because these patients are clinically are very bad condition, like New York Heart Association class 3-4, and right ventricular function is very much important. But usually we don't do just a little, I'll mention about technique, we usually perform on-pump surgery, but we don't cross-clamp. Therefore, I think our mortality is can never be around 30%. It's always been less than 10%. Even 10% is a very high mortality. We don't arrest the heart at all. And even when we are doing a concomitant surgery, we finish our left side surgery and then let the heart beat. And then at the beating heart, we perform our tricuspid surgery. You can see the tricuspid regurgitation here and ring and anatomically correct design of the ring. In decision making of tricuspid valve repair or versus replacement, I'll mention a little bit about that. Repair is associated with better perioperative, midterm, and event-free survival than replacement. This is a common idea at the moment. But despite more tricuspid regurgitation in the repair group during the follow-up, reoperation rates and functional class were similar. You can see at this paper that repair and replacement operative mortality are the same almost, but surgical treatment of tricuspid disease, regardless of operative approach, is associated with significantly early and late mortality. There is no difference favoring tricuspid repair over replacement. So it's a little bit confusing. Although we generally and in all of the world, all over the world, there is a common tendency to perform repair. When you evaluate the results, there is not a big difference from the mortality point of the view and the survival rate of the view. Then when should perform and whom, why, results for tricuspid valve replacement. As it was mentioned by previous lecture, the good old Divega, good old K, ring annuloplasty, they all have good results. If you can see the basic style of surgical techniques here, I'm just skipping that for the sake of the time. And if you look at the database of Society of Thoracic Surgeons of National Cardiac Database, you can see that after 2004, the number of the tricuspid valve replacement is so less, and the valve repair is increasing. Database shows this, but there is not, although there is not great difference between the results. Should we use mechanical or bioprosthetic valves for tricuspid valve surgery? Mechanical prosthesis reveals good results in mitral and aortic position. But are they good enough in tricuspid? We always try to use bioprosthesis, but there is no great scientific paper supporting that bioprosthesis has advantages over mechanical valves in tricuspid position at all. When we look at the thrombosis instance in biological and mechanical valves, in tricuspid, there is not very much difference between aortic and mitral valves as it is seen here in annals. And also, if you look at the mortality and survival rate between the mechanical and bioprosthetic valves, there is not, again, a great difference. And we had some, recently, we were using a different brand of bioprosthesis in tricuspid position, and recently the St. Jude valves has introduced us third generation, second generation bioprosthesis, but we realized that between 2007 and 2012, we realized that our results are not as good as the previous results, and we have started to investigate it because there was no difference in the early postoperative period. There was no early postoperative death at all. But after the 6 months, after the 8 months, we started to have gradient with St. Jude medical bovine pericardial valves in tricuspid position recently, although we didn't have any in Sorin, Hancock, and Edwards in the past. You know that they are again glutaraldehyde fixed valves, and they have very good cooption like good old Ionescu Shiley valves. But I think that there, because of the, I can jump all these our data, and I think that reoperation rate were lower in the previous years' bioprosthesis that we have used in tricuspid position. These are the cases. There were no difference between the two groups. After the 400 days of follow-up by transthoracic echocardiography as well, we decided that we are having high gradient after the tricuspid valve replacement by St. Jude bioprosthesis, then by bovine prosthesis, then we stopped to use St. Jude bioprosthesis in tricuspid position in this year, very recent. When we check the literature, we have realized that there are a lot of reports about bovine pericardial prosthesis in tricuspid position. So even for bioprosthesis, there is not a very selective, better results, and you can see the biological and mechanical valve differences in the other series, United Kingdom series here. There's not much difference. So, and also if you look at the patients, most of them are having AF. So if they are having AF, the anticoagulation Coumadin usage is not a problem, so you can easily use a mechanical valve. Also, if the age is important for the elderly, we are using bioprosthesis. For elderly, there are a lot of reasons that you have to use, as I said, like AF, anticoagulation. So mechanical valves can be implanted in tricuspid position as well. Thank you very much for your kind attention.
Thank you very much, Professor Oto. Now both this presentation are open for discussion. Dacă cineva are întrebări către domnul profesor Oto sau domnul conferențiar Moscalo, vă rog. Please, Dr. Diana.
Thank you for your presentation. The question is, the recent era, which is your first choice for tricuspid replacement, is mechanical or biological and biological risk valve?
As I mentioned, normally there is a tendency to use bioprosthesis, but we were using Edwards and all the other brands of bioprosthesis so far, and we were introduced recently this St. Jude valve. Whatever, even in the other bioprosthesis, in 6 years or so, at least 10 years, we had to replace it. And if it is, and sometimes because of this tendency, Even we have a mechanical valve in mitral valve, we were using bioprosthesis in tricuspid. So now we realize that it's a great mistake. We are inviting a reoperation for ourselves in at most 10 years. And there is no difference between the usage of mitral mechanical valve and bioprosthesis when we carefully see all, investigate all the papers around the world. Therefore, I started to use very recently, after this St. Jude event, I started to use mechanical valves when it is possible, just to avoid reoperation. But when I say this, having said that, people can blame that if we implant an bioprosthesis, later on a catheter-based tricuspid valve can be implanted as well. So I am on side of mechanical valve recently, after the all experiences.
Which mechanical valve?
Any bileaflet valve, but mostly I use again St. Jude mechanical valve.
Is there a position you prefer for bileaflet?
For bileaflet valve, I prefer rectangular to, perpendicular to the septum. Yes.
Patients with infected endocarditis in tricuspid position.
Yeah.
You prefer repair the valve or replacement? If you decide to replace the valve, what kind of valve would you put in this?
Yeah. So far, as you have kindly emphasized, so far, whenever I'm in need, of course, I try to repair if there is an endocarditis. And you know that in the past, there were some recommendations that if it's a severe endocarditis, just resect the tricuspid valve and leave it like that. It works. There was one of the papers in your slides as well. Do we need tricuspid valve? Something like that. I remember that paper. So it is such a thing. So basically, we prefer repair. But as I mentioned you, as a trend, so far, we were using bioprosthesis. But really, I don't see any point that we have to continue to use bioprosthesis because we have endocarditis and it can be repeated. And then what will happen? Then we will have a reoperation in 5 years to 10 years at most. What's your tendency to use in bioprosthesis?
Depends. If we can repair the valve,
Repair.
if we have cases with need the replacement, we put the biological.
Yeah. Yeah. From my residency till to last year, we were using always bioprosthesis, and then we realized that there is no point after searching the literature. There is no point of using bioprosthesis. Just it's a habit, tendency.
Mai sunt întrebări? Mulțumim. Thank you very much, Professor Oto.
Eu aș vrea câteva cuvinte. În primul rând vreau să mulțumesc domnului conferențiar Vitalie Moscalu, colegului nostru, și domnului profesor Oto pentru două comunicări foarte importante. Pentru noi, o problemă care, după cum vedeți, încă rămâne discutabilă și până în ziua de azi, în cardiochirurgie. Și totuși s-au pus problema, sunt două probleme majore, de recidivă a insuficienței tricuspide, complicații care noi le-am văzut aproape în 5% de cazuri în comunicarea domnului Moscalu. Deci ele cred că depind în mare măsură de hipertensiunea pulmonară ireversibilă sau cu o regresie minoră după tratamentul chirurgical, mă refer mai mult în patologia reumatică mitrotricuspidă. Și rămâne o problemă, totuși, protezăm valva tricuspidă, atât în endocardită, cât și când morfologia valvei tricuspide nu ne permite să facem o plastie. Care proteză de folosit? Biologică sau mecanică? După cum vedeți, aceste întrebări rămân până în ziua de astăzi. E discutabilă problema pentru că și la noi punem prioritar bioproteze diferite, dar avem și un caz când s-a implantat la un copil deci bioproteză, după aceea o dat endocardită de bioproteză și cu disfuncție și am implantat valvă mecanică biliflet care și până în prezent copilul se simte foarte bine. Deci cazuri în literatură sunt diferite cazuri care dau prioritate la valvele mecanice, însă prioritară sunt valvele biologice. Pe mine m-ar interesa totuși recidiva de tricuspidă. Rămâne discutabil și aș vrea dacă cineva să-și spună părerea pe acest caz, anume cum este legată recidiva de tricuspidă după corecție în hipertensiunea pulmonară cronică când se fac operațiile de trombeenterectomie în trombembolia pulmonară cronică. Deci când merge și cu plastia de valvă tricuspidă, în dependență de hipertensiunea pulmonară care e irreversibilă sau cu o regresie minoră. Dacă se poate, domnul profesor Tinică, câteva cuvinte, părerea dumneavoastră.
Vedeți, astăzi s-a vorbit în cele două lucrări care au fost prezentate de dimineață despre tratamentul chirurgical al tromboemboliei pulmonare și în ambele lucrări s-a menționat faptul că se fac corecții și tricuspidiene atunci când este cazul. Și în majoritatea cazurilor, după tromboectomia pulmonară, avem regresia insuficienței tricuspidiene. Și cu toate acestea, unii autori recomandă că chiar dacă nu avem modificări majore, dacă avem diametru inelului tricuspidian mai mare de 40 de milimetri sau de 21 de milimetri pe metru pătrat, atunci să-i facem corecție tricuspidiană. Dacă nu scade hipertensiunea pulmonară, înseamnă că ori indicația de tromboembolectomie pulmonară n-a fost făcută corect, ori operația n-a fost efectuată corect. Doctorul Caiu Străian o să-mi confirme sau o să-mi infirme această ipoteză, dar în asemenea situații, dacă nu regresează insuficiența tricuspidiană, înseamnă că noi am făcut tromboembolectomia pulmonară cumva ori în insuficiență, ori degeaba. Asta este părerea mea. Sunt experți în această problemă și poate cineva, dacă Caius vrea să ne spună două cuvinte, te rog, Caius.
Nu am urmărit în mod special reacția insuficienței tricuspidiene după tromboectomia pulmonară, dar e clar că mulți dintre pacienți au avut, într-adevăr, secundar o insuficiență tricuspidiană severă, care în unele cazuri poate că ar merita urmărită mai cu atenție. Dar așa cum a spus, zicem noi, la majoritatea cazurilor la care hipertensiunea pulmonară totuși a regresat post-operator, sigur că ne așteptăm ca și patologia tricuspidiană să se amelioreze. Dar asta nu înseamnă că n-ar trebui să luăm în considerare o operație concomitentă de reparare, în special de reparare, mai puțin poate de înlocuire, dar de reparare a valvei sau de plastia valvei tricuspidiene concomitent cu tromboendarterectomia pulmonară. E clar, așa cum a spus, dacă indicația nu este corectă sau dacă există embolism distal care duce postoperator la menținerea hipertensiunii sau uneori chiar agravarea hipertensiunii pulmonare, e clar că și regurgitarea tricuspidiană va fi la fel de severă și va avea o evoluție nefavorabilă. Da?
Poate aici ar fi indicat dacă am putea să găsim niște factori predictori ai evoluției regurgitării pulmonare, regurgitării tricuspidiene, ar agravării, poate ar fi cazul să completăm și cu o protezare tricuspidiană. Nu știu, eu pun întrebare.
Da, asta a fost ideea, pentru că dacă noi rămâne o hipertensiune pulmonară avansată, orice plastie, orice reconstrucție de valvă tricuspidă poate să nu dea efectul dorit și atunci o protezare poate să ne